having a medium volume here, we do around 4 to 5 complex cases per month, other than the routine PCAs. Of this complex 4 to 5 cases, we do like 2 to 3, which usually involve a bifurcation strategy. Either could be provisional or could be a dedicated bifurcation strategy. Usually my motto will always be to preserve the side branch access with minimal strut or metal. So I preferentially use professional stenting. Sometimes if I suspect the compromise of side branch is more, or the angulation is too narrow, or the side branch is a bigger branch more than 2.5 mm, I usually go for dedicated bifurcation stenting. My biggest challenge would be planning of the case, whether this patient really needs a second stent or not. If my planning is clear, then usually our technique will be as per the protocol, so usually we don't face any challenges. Don't usually encounter such uncovered area because I always plan before proceeding. So rarely, if whenever once or twice when I went for provisional stenting, then I have to convert it to T stenting. Rarely happened, but I remember like covering entire bifurcation area. So with IVAS guidance, these days losing the area is very minimal or near to impossible. This is a very important question. Stent design, flexibility and trackability are the key parameters for any interventional cardiologist, because these are the final stent design technology which helps us to place the stent. Okay. And without these, neither we can place the stent or open it in a proper way for further expansion. These are the main things which we do. Adequate predilatation, and optimal positioning. These are the key factors for optimal side branch access or flow. We never tried dedicated or bifurcation stents. I never had an experience with those kind of stents. In a provisional strategy, with side branch flow without any compromise, which is a TIMI 3 flow, and reasonable or side branch ostial area without any compromise in the flow, I would call it is a good result. And in a dedicated bifurcation strategy, maintaining the adequate TIMI 3 flow and proper able to recross balloons in both the branches after the bifurcation without any hindrance, I would say this is a good or optimal outcome. Definitely maintaining a TIMI 3 flow, good flow always helps a good myocardium to grow. So in my experience with good side branch flows, I had patients who had very good improved EF. So maintaining a side branch flow is very important, and it will definitely have a good outcome. Definitely, if data supports for any dedicated bifurcation stenting, and if they are technically compatible and has a good trackability and accessibility, definitely we would like to try dedicated bifurcation stents. Most of the currently available open stud design has eased the way of stenting in bifurcation. Previously, the closed stud designs were very difficult to access for the side branch. Right now, most of the stent companies have opted for open cell design, which most of the times is very helpful for placing a side branch stent to the main branch. How easily it is available and how easily one can access the side branch through the main branch. These are the factors, and how well the Carena optimization occurs with these dedicated stent designs need to be studied, and most of the cardiologists, we need to have hands-on training on this kind of dedicated stents also. So maybe it will take some time. If this kind of stents has good outcome and good data comes out, everyone would be very happy to do, because it will save a lot of time as well as prevent much radiation exposure for the doctors.